Hello again. Now we are going to move from clinical uh, decision making to the nursing process. This is how you're going to make clinical decisions by using this 5-step process. So our learning objectives, again, they're by the end of this unit, you're going to know those 5 phases of the nursing process, the relationship among the phases of the nursing process. You're going to be able to organize assessment cues that are relative to each other into a pattern. You're going to be able to formulate a nursing diagnosis statement, plan care. That means in thinking about the priorities of care, the client goals, and selecting nursing interventions. And we'll talk a little bit about revising the nursing care plan based on your evaluation. So, the nursing process is used to identify a patient's health status, actual or potential health problems or needs. It, we use it to establish plans to meet the identified needs, to deliver specific nursing interventions to meet those needs, and to evaluate the success of the interventions that we come up with. You see, I have our little lady up here, and she's saying, that's a lot. That little student says, that's a lot, and it is. But again, you will see on the front of the first slide, I had a brain, and I said, this is training your brain to make connections. So the nursing process is patient-centered and it's holistic. Nursing is different from other healthcare professions because it is so holistic. Physicians go by the medical model, and then the other disciplines tend to be centered on a certain focus, like respiratory therapists is centered on breathing and the respiratory system. Physical therapists are on mobility and moving. But nursing is unique of all the healthcare professions because it is holistic. And that means that when we are considering care for a patient, we've got to consider the emotional and the spiritual well being of the patient. We're going to collect data that's going to consider the psychosocial and oftentimes socioeconomic needs of the patient. And we're going to address the physical and the biological. So, nursing being holistic is going to address the physical, the emotional, and the spiritual, and then sometimes that psychosocial and the socioeconomic aspects of a patient's care. So the nursing process has 5 pieces: assessment, diagnosis, planning, implementation, and evaluation. So we are going to very carefully go through each piece of this puzzle that is the nursing process. You will hear me refer, I think your book is referring to them as phases: the assessment phase, the diagnosis phase, the planning, the implementation, and the evaluation phase. I tend to like to use steps because they are steps and they are pieces to this puzzle. So either way, just know that I may go back and forth between phases and steps. So the first step of the nursing process is assessment. And with assessment is going to drive all the rest of the nursing process. It is an essential first step. And with assessment, we are going to observe and we are going to collect data. We're going to organize that data and then we're going to validate that data. You can see all of the phases of the nursing. I want to reiterate, all the phases of the nursing process depend on assessment, on collecting data, organizing it, and validating it. And this is, you're going to do your planning on what you assess, not what you think you're going to assess, not what you think is going to happen tomorrow. You are basing this on what is happening today with this patient when you collect this data. Now, you want to project into the future because whatever problems you come up with, you want to correct them. So, we have um, we've just said that in order to do an assessment, we've got to collect data, we've got to organize it, and we're going to validate it. So how are we going to get this data? Well, when we go and check on our patients, we are going to be observing them. We're going to be interviewing them, particularly if this is an admission assessment, and even with the shift assessments. And we're going to do a physical exam. So we're going to use those three methods to gather the information that we need on this patient. So assessment, again, is crucial. It is patient-centered. And if you're thinking about that, you've got to address the emotional and the spiritual, the psychosocial. We can't exactly do a physical exam to get that information. So we have to be observant. We have to observe the patient's affect, meaning are they happy? Does their face change when you're talking to them? Are they animated? Do they look sad? Are they grimacing? Do they look like they're in pain? So we're going to use skills of observation for assessing. When when we're getting ready to send them home, we're going to send them home perhaps on a medication that's kind of costly. So we're going to be interviewing to find out, okay, can you afford this? Can you afford this medication? If not, we may have to think of something else. And also with interviewing, when we're admitting a patient, or even day to day when we're taking care of a patient, we're going to be constantly interviewing them. How are you feeling? Oh, you're having pain. Can you please assess that pain on a scale of 0 to 10? That's interviewing. You're asking what, when, why, how questions, interviewing. And again, the physical exam is self-explanatory. So when we collect this data, we're going to have either objective data or we're going to have subjective data. So in our assessment, objective data are observations that can be seen, heard, smelled, touched. They can be measured. And these are the assessment data that's like a blood pressure, pulse, respiration, or a wound. So again, there are things that can be measured. They can be seen. They can be heard, smelled. With your senses, you are going to observe this data, and that is considered objective data. So usually in your interview assessment or in speaking with the patient or even with the patient talking back and forth to you or even from your observations, you are going to obtain subjective data. Subjective data is data that is an expression of feelings or perceptions. It can be described and it can only be verified by the patient, and that would be such things as pain, anxiety, or itching. There's no way that you can touch pain. There's no way you can touch anxiety. There is no way you can measure it. You're going to ask them to measure it on a scale. However, you're not experiencing that pain. So you cannot verify that. You just have to go by the patient's expression and what they say it is. So there are different types of assessments. We have a continuous assessment is continuous. Excuse me, let me back up. There are different types of assessments. Assessment is continuous. You are going to assess patients all day long. And but there are different types of assessments, and they are for specific periods of time. The initial or baseline assessment is usually done upon the admission of a patient to a unit or to in the emergency room. You're going to get a baseline assessment, but it's not going to be as thorough as the assessment that's going to occur up on the acute care unit. The first time you go to a doctor's office, do you remember the long, long forms that you fill out? That's usually a longer visit. That is getting baseline information. And I forgot to mention when we were talking about interviewing to collect your data, when we get medical histories, we are interviewing. So this is baseline assessment, and it usually is a more thorough assessment. You see with my little picture, she's looking in the patient's mouth. Again, it's going to be a little more comprehensive than, say, the shift head to toe. It will be head to toe, and again, you'll be taking a history and a history of the current problem and of past medical history with an initial or baseline assessment. A problem-based or system-specific assessment is an ongoing assessment that occurs during your course of the day. Let's say that you're in intensive care and this patient has gone into like a hypovolemic shock. Well, as a result of that, your urinary output is going to be very low. So a problem-based or system-specific based assessment would be hourly intake and output on this patient. Another problem-based or system-specific assessment might be, let's say the patient was admitted with pneumonia, then you're going to be checking O2 sats, their lung sounds, and you're not going to just do it in the morning because things change. Their O2 sets may be fine first thing in the morning, but you can't let that go all day because the tighter they get in the day, the harder they're going to have, it's harder it is to breathe because all of those muscles start to get tired. So you're going to be checking O2 sats and lung sounds throughout the day. And instead of that head to toe assessment where you're checking neuro, you're checking their head, their chest, their heart rate, their skin, their bowel sounds, you're just going to focus on the respiratory system. An emergency assessment, I think, is self explanatory. It's assessments that we do in times of crisis, and that can be a physical emergency or it could be a psychological emergency. Let's say someone is threatening to commit suicide. So, emergent is an assessment that is done in a crisis type of situation. An ongoing assessment, it's very similar to the problem-based or system-specific assessment. It can be ongoing minute to minute, or it could be ongoing month to month. So it's something you have your baseline data, you know what your patient was like when they were first admitted. So you're going to continue to monitor them to make sure that either things are improving or things are staying the same, or perhaps they are worsening. And your ongoing assessment would be something like a patient is admitted to the hospital with a critically high blood pressure, and you get it under control in the hospital, and then they follow up in the physician's office for monitoring of that blood pressure. That would be an example of an ongoing assessment. So with assessments, let's say you go into your patient's room this morning and you jot down all of these symptoms, these random symptoms. Your patient has a productive cough. They have a sad affect. You notice that they have right hand weakness. They complain of a disturbed sleeping pattern. They have, it's morning, so they've just gotten up and that moving around, they've had a little coughing spell. So you note that there's foul smelling sputum that they have produced. Their temperature is 102.2. They have a respiratory rate of 28 when you know that that a normal should be between 16 to 22. They have inspiratory and expiratory crackles on auscultation. And I'm going to start using terms with you that you need to be incorporating into your documentation. So inspiratory and expiratory crackles on auscultation just means that when the patient breathes in and when the patient breathes out, you're listening with a stethoscope. That's what auscultation is. You're listening with a stethoscope and you can hear crackles. I probably should have put coarse crackles right there. They have shortness of breath and they state, I don't feel good. And you also note that the sputum is green colored. So here you have random symptoms. They're all in the same patient, but there's just a mixture of different symptoms. So let's first practice with which ones of those are objective and which one of those are subjective. I would prefer that you pause the recording and try to figure it out before we move forward. Okay, the objective symptoms would be the productive cough, the right-handed weakness, foul smelling sputum, the temperature of 101.2, a respiratory rate of 28, inspiratory and expiratory crackles. Shortness of breath actually can be either one because you can actually see the shortness of breath, or a patient can complain of shortness of breath without any visible or measurable symptoms. So, shortness of breath could be either one. And green colored sputum, those are your objective um, cues or symptoms. So, your sad affect, your disturbed sleeping, and the statement, I don't feel good, those are your subjective cues or symptoms. You can't measure those. Those are by patient report. So hopefully that kind of helps. So let's look at our symptoms. All right, obviously there's something going on, and obviously we have a problem here with this patient, correct? So we need to look at these random symptoms and we can then cluster them. So the common thread seems to be the respiratory symptoms. So the productive cough, the green colored sputum, the foul smelling sputum, that temperature indicates infection, shortness of breath, the increased respiratory rate, and the crackles. All are a cluster of symptoms that point to a specific problem. So we have just used deductive reasoning here as well, okay? So we've gotten general random symptoms. We are beginning to break them down, and we're going to pinpoint a problem taking this cluster of symptoms. So our significant Q cluster, we just said, was the productive cough, the green colored sputum, the foul smelling sputum, the temperature elevation, the shortness of breath, the increased respiratory rate, and the crackles. Okay, those are all your significant cues that are clustered together. So, are there things about these clues that the nurse can take independent action to treat? Yes, there are. So this is our assessment data that we have identified and we have clustered, and we're figuring out there is a problem related to this cluster of cues. So our next step would be to define the nursing diagnosis or problem statements using this cluster of cues. So this concludes assessment. So I'm going to stop here, and then just you can go ahead and open up the diagnosis, the nursing diagnosis PowerPoint, or you can go back and review this one and to try to help to try to understand assessment better. If you have any questions, please see me.